Hi, my name is Holly Vanderhyde, nurse practitioner with Destiny Hospice and Palliative Care, and today I'm going to talk about explanation of benefits. So why do we do an explanation of benefits? Well, we all know it's to get somebody admitted to hospice, but it's also to explain things to them so that they understand what they're doing and why they're doing it. A thorough EOB can prevent later misunderstandings and revocations. Anyone who's done a hospice EOB or admission knows that there are often misunderstandings, even if you are as clear as you can possibly be when you're going through all the information. There's lots of information for people to retain, and so the more thorough you are at the beginning, the fewer problems possibly you'll have later on. You need to give enough information so that they understand exactly what's going on. This is either the patient or the family or both, but not so much extraneous information that things get complicated and people get more confused. There's a thin line between thorough understanding and information overload. So one of the first questions you want to answer in your head and then be able to elicit information from the family or the patient is why hospice and why now? So if you just ask why hospice and why now, that's kind of short. You have to say it in a way that feels natural to you. Some of the things I say are, how did hospice come into the conversation? Or what happened recently that brought hospice into the equation? So just to kind of get a feeling, get the conversation started as to why we're looking at hospice, what's different than a month ago that makes hospice a possibility now. Then once you go through that story, it's not going to be a little 20-second thing. Usually they're going to probably go over the decline and the things that have happened, hospitalizations, whatever it happens to be. Then you want to find out, what do you know about hospice already? Because if somebody has prior hospice experience and you start from the beginning, it might be quite different than the experience they had. So you want to know if they have experience with hospice before this. So when you're doing the EOB, these are the sections in our patient and family education booklet that we give to them when we do the explanation of benefits. And it would be a little lengthy to go through all those sections, but the three most important ones as far as making sure people understand are the patient rights and responsibilities, symptom management, and preparing for the dying process. Those are the specific things that I point out to people when I'm speaking with them. So these sections I'm going to go over are important simply because when you get to the consents, these are the things that you say that you've discussed with them. And so it's a good thing to bring them up ahead of time before you actually ask for signatures. Responsibility starts on page 17 in the current booklet. And one of the most important things is cooperate with your doctor and hospice staff. We have, various staff members who are there to help you, and we need your cooperation in order to get the best outcome for you or your loved one. Let us know if there are any changes in condition. That's why you have that 24-hour number. You can call us anytime during the day. It will be the number will be answered by office staff, but there's always medical personnel around to ask if any questions are out there. And then in the evenings and weekends, after hours, a nurse will answer that phone, and they're well versed in any conditions, any symptoms, any medications that you might have questions about. So make sure you take advantage of that 24-hour number. Follow the plan of care. There's a plan of care for every patient. It's individualized to that patient, and we will expect you to follow the plan of care because that's the way to get the best result. Agree to visits from nurses and other hospice staff. The nurses are the cornerstone of hospice care. If the nurses can't get in to see you or your loved one, whoever the patient is, we can't do our jobs. We have to be able to assess that patient. And then the same with other hospice staff. They're all there to help you, to make your journey a little easier. And so whether it's the aide, that aide is not there unless you asked for them. So let them come do their job. If you have a social worker or a volunteer or chaplain visits, cooperate with having them come in and help you so that they can do their jobs as well. Make sure you let the hospice staff know of any changes in advance directives. The routine visits, they'll always be kind of maybe checking on that. If you, for example, start out as a full code, it's important to let these folks know that, yeah, we'll be kind of asking you when we come do our visits if you still want to be a full code. And that is because as people decline, often they've changed their minds, but they just didn't think to say anything, or they didn't think it was important, or they forgot. And so just let them know, if you're a full code, we probably are going to ask you intermittently if you still want to be a full code based on your condition at that time. And agree to follow the rules relative to pet containment. There are nurses who have been injured by pets, even though pets normally, the owners say they don't bite. You never know how an animal is going to react to a stranger. And so if you need to put an animal away in a different room, please do so. And don't be upset or angry with us, because we go into a lot of different people's homes. We interact with a lot of different types of folks, and all those folks might have different kinds of pets. And so sometimes it's best for everyone across the board to have the pets in a different room or a crate, or however it is that you separate them from other people. And it's not that nobody doesn't like your dog or your cat or whatever the animal is. It's just for safety. Symptom management starts on page 41. And this is the section that talks about things to expect. Symptom management is always our number one priority. Pain specifically, but any of the other things that are going on as far as anxiety or nausea or bowel issues. And if you are not the nurse and you're doing just the EOB and you're not going to be doing the admission, just let them know the admitting nurse will talk about the medications to control the symptoms, and make sure they understand that. And then once the medications are delivered, we deliver them, everybody gets them. It's in case we need them when we are called out in the middle of the night or on weekends, and your nurse can go over all those medications with you again after they are delivered. And then the other section I always like to point out starts on page 47, preparing for the dying process, and that is such good information to have. Please read that at your leisure. There's a lot of information in there, but it's really good to have in the back of your head before anything serious happens, so that when you do see those signs, okay, this is expected. This is something that doesn't just happen to this one person. This is just part of the decline that we expected from the beginning. And once again, once those things happen, yes, they're expected, but if you need reinforcement or a nursing visit, call us on that 24-hour number and we can decide what's the best way to go about that. Patient rights and responsibilities. This is one of the things that is on the form that they sign on one of the consent forms. So there's a lot of information. I think it's 2 or 3 pages of patient rights and responsibilities. But the things that really are important to point out are that you can have input into the plan of care. If we're doing something you don't like, or if we're not doing something you think we should be doing, please talk to your nurse or case manager so we can figure out what the best way forward is. To be treated with respect and have your decisions respected. To receive clear information. We'll explain whatever we're doing the best we can to make sure you understand it. You can stop or change hospice providers as you see fit. If you wake up a month from now and decide, my gosh, I don't want to do hospice anymore, talk to us. And if we need to take you off, we'll take you off. You are not signing your life away, so to speak. You are not made to stick with a specific time frame. It's all what you need and when you need it. And then, of course, the right to privacy and quality of care. We can just kind of talk about HIPAA a little bit, that we're not going to be giving any of your medical or private information to anybody who doesn't need it. The consent forms we sign when we do an explanation of benefits. There's 5 of them. The admission consent, it's multiple sections, as you can see. And the patient rights and responsibilities, you've already talked about that. You went through what those were. And you can reiterate, if they have questions, do you have any questions about what's going on, about your rights, or what we expect from you? And then the consent for treatment, just we're coming in to take care of you, and you're going to be following your plan of care, and just kind of reiterate those things that you already talked about. Release of information gives us permission to request records from doctors or hospitals if we need them. And, we usually get a few records before admission, but quite often we need something more. And if we have that release of information, that gives us the ability to do that. Authorization for payment, I simply say Medicare pays us directly for hospice care, you don't pay us. Consent to film or record, that is normally, and I tell them this, that is normally if you have a wound or your loved one has a wound that is getting better or not getting better, sometimes we'll take pictures of it because we want to see the progress and if we need to change the wound care that we're doing. Admission consent special services. Make sure you are very clear that any care outside of us is not covered by hospice and may or may not be covered by your insurance. So for example, years ago we used to always tell folks, do not call 911. Well, that's really unrealistic because if somebody has a broken bone, with the bone sticking out of their skin, they probably are going to call 911 no matter what we tell them. Or if somebody's got uncontrolled bleeding, 911 is the right call to make on that. But make sure you make them understand if you call 911 first, you have to call us second, because we have got to be in touch with the hospital and make sure they know that this person is on hospice for this specific condition, and that way you will not get a bill, you being the family or the patient. Make sure they understand if they go willy-nilly getting treatment for something that is relative to their hospice diagnosis, their insurance may not cover that, and they may end up getting the bill for that. And the revocations, obviously if somebody gets admitted and we don't know what's going to be going on, a revocation is going to come into the conversation. Now, say for example that somebody is on for cancer with metastasis. They fall down and they break their ankle. So if they go to the hospital, which they probably will, or urgent care or whatever, they just need to make sure that the person who's treating them knows I'm on hospice for my cancer. If it's not bone metastasis and it's just a regular break, small break, and they treat it and leave somebody alone, we need to know about it, but there may not be any reason for revocation. Now, where it could get hairy is if somebody has bone mets, the place they break is where they have cancer metastasis. So it is kind of related to the cancer, because had they not had that metastasis and that bone degeneration from the cancer, they might not have had that break. So once again, we always have to know about all that stuff as soon as possible, and we may need to do a revocation for that and then assess them when they get out of the hospital and see if they are eligible to be readmitted. Never tell somebody that, oh, you just go to the hospital and then once you get out we put you back on. Always make sure they understand there is another evaluation involved in that. It's not a given. So always make sure folks know if you come off because of a revocation and you went back on, we have to evaluate you again. And that's the perfect time to make sure they understand all this information that I just talked about as far as outside care and getting a bill if they do not let us know immediately, so that we can kind of run interference and make sure that whatever is done is something that is going to be covered by insurance, because it's not going to be covered by hospice. And then with any kind of symptom management, it's not bleeding, it's not broken bones, it's nothing life-threatening, call us first. If it has anything to do with breathlessness, pain, any of that stuff like, that we give them the medications for, call us first, because just because somebody's in pain or is having trouble breathing doesn't mean they need to rush to the ER. That may be the case, but we need to know about that so that we can make that decision and help them make that decision. Consent for election of Medicare hospice benefit. This is kind of rolled into the getting a bill thing, because when you go on to hospice, you are giving up the routine Medicare coverage. So that means anything having to do with your hospice diagnosis is covered by Destiny Hospice. Your insurance, if you are on for COPD, chances are your insurance is not going to pay for oxygen, because that's our job. We need to give you oxygen. Now, the broken bone or the uncontrollable bleeding, this is related to the prior slide, that if you do call somebody other than us, make sure you call us second. Very, very, very important, because the patient does not want to get a bill, because then they'll want the hospice company to pay for it, which if we did that for every person who went to the ER, we would be not working. But also make sure that you let them know, and this is partially the admitting nurse will go over this as well. But whatever medications you feel like you still want to continue to take, if you're on for COPD and we're going to be taking care of the COPD symptoms and signs, but you want to take your heart medication, your insurance will continue to pay for that heart medication, because those two things are not related. Consent for primary caregiver. Remember, the caregiver goes on the first line. Patient goes on the second line. That's real easy to get backwards. Make sure they understand hospice is palliative, not curative. We give you training and support, but we are not there many hours a day to actually take care of the patient. Some people do expect hospice personnel to be there for hours a day to do things, or to come and change diapers or whatever. And you've probably seen calls like that. Where, well, so-and-so is covered with poo and I can't do it myself. We need to bring this up when we do the EOB, that we are not there for routine care. We have our routine visits, but we're not able to be there for hours and hours and to just come for diaper changes and things like that. We've done it, but we want to point out ahead of time that that is not our actual function. That's not what we are supposed to be doing. Make sure they understand that they know that that person cannot be left alone, and whatever care is necessary for them, it's their responsibility to make sure it's there. And I already covered we're not there for an hour or so. And I specifically say, we're there between a half hour and an hour, however long it takes to either, change wounds or change wound dressings or give bed baths, whoever happens to be doing the care that's going on at that time. That's how long we're there, however long it takes to do that particular care. And then make sure they understand that they are indeed responsible for the care of the patient, and they're accepting that responsibility. Acknowledgement of information. They need to just agree, yes, I will take care of this person to the best of my ability. And I understand that if there is care involved that I can't provide personally, I'll make arrangements to make sure that care is provided. We don't want to get into a situation, which has happened, where the patient is not well taken care of. I mean, I've seen, we have patients that have been covered with ants and, just various crazy things that people who are supposedly the caregivers don't understand that that's their responsibility, and they need to be aware of that. If you have problems, it's written out on page 12, please tell your nurse first. Just tell us and see if we can fix things. Don't let things just sit and fester until you get mad. Just let us know. We want to cooperate with you. We're here to make your life easier, not to make it harder. And we want to try to help as much as we can to make that happen, to have the patient be comfortable and well managed. And then the numbers are in the book on this page 12, the toll-free number and all that jazz for the state. So the preferred intensity of care, kind of related to the POLST. If they're not sure about what they want to check, they're looking at it and they're thinking, oh, I don't know, I never thought about this stuff. I always tell them these things. You know, leave the x-rays in case somebody breaks their finger and you want an x-ray. IV therapy in case they get dehydrated, end up going to the hospital because they called 911 and they can have an IV or antibiotic, and then the lab studies, because you never know when you might want to do a urine or a blood sample, and that usually makes them feel pretty good, unless they've already decided, yeah, I want everything, I want TPN, I want a ventilator, I want everything available. Then they'll be able to figure it out on their own. POLST form. Sometimes if you are not doing the admission, you leave this for the admission nurse, and sometimes people who are not doing the admission will do this. So I'm going to cover it for anybody who needs it. The website at the very top is where I got the information on here. If you have any questions, please go to that website and read it. Section A and sections B and C are kind of separate. So section A only applies if your heart has stopped and there's no breathing. So it either says do CPR and try to bring me back, or step away and leave it be. If you choose full code, yes, you want CPR, you have to choose full care in section B. So if you decide, yeah, my heart has stopped, I'm not doing anything, but I want you to do CPR, they're successful in bringing you back, getting your heart beating again, you have to choose full treatment in section B. Now, if the patient is found alive and they are taken to the ER for whatever reason, and they have not done CPR, you can select full treatment, selective treatment, or comfort-focused treatment. So regardless of what you have up in section A, say you have attempt resuscitation, but when you were found and taken to the hospital, your heart had not stopped and you were already alive, then you decide, okay, once I get to the hospital, do I want them to do everything possible? Maybe do everything possible for a specific period of time, for a trial period, which would be full treatment. Do I want selective treatment, which would include IV fluids, IV antibiotics, maybe a CPAP or non-invasive breathing assistance? Probably not go to ICU. That's selective treatment. And then comfort treatment is just give me whatever drugs are necessary, oxygen suctioning, to keep me comfortable, and whatever happens, happens. So, and this last section down here at the bottom is directly from that capulse.org website. You can say no CPR and full treatment. And what that means is, if I'm dead, don't try to bring me back. But if I get into the hospital and I'm still alive, I still want you to do everything you can to keep me going. So I highly recommend that you take a look at that website, because it is pretty informative as to what those various things mean. When you are going over the feeding tube business, a lot of people get confused about that. Oh, I don't want them to starve to death. They are not really educated in what a feeding tube is for and what it accomplishes. So one of the things I like to bring up is that studies suggest that dying patients do not experience hunger. If you are so debilitated that you are unable to swallow, if you are already sick, you already have a life-limiting disease, and you end up in the hospital and you're unconscious, putting a feeding tube in you, whether it's an NG tube, TPN, whatever, it's not gonna fix you. It's not going to make you better. It might keep you alive a little bit longer, but it's not going to really change your condition, because what put you in that unconscious state or made you unable to swallow has nothing to do with eating. It has to do with disease process and debilitation. So if somebody does not have a feeding tube, in the last few days or weeks of life, a lot of folks will force themselves to eat just because their caregiver wants them to eat. And it's not that they feel hungry. It's often they have no desire to eat. The thought of it just makes them want to vomit, but they'll keep trying because they're trying to please the person who's taking care of them. So just make it clear that if somebody is confused about whether or not to use a feeding tube, they were designed to get somebody through a short-term problem. Maybe they had surgery, or they had something wrong with their throat and they couldn't swallow, and they were going to get better as long as they had nutrition during that time when they were recovering. But in a situation where you're on hospice, like we just talked about, that feeding tube is not going to change the outcome. It might prolong things, but it's not going to change the outcome. And in fact, when you are on your way out, giving food and water can often make people less comfortable. You've heard of fluid overload. You do IV fluids or even fluids by tube, and your body can't metabolize. It can't handle the extra food and fluids, and so you get constipated, or you vomit, or you get fluid overload where your extremities or even your body swell up because you just can't. It's not working right. It's not doing what it's supposed to do. And so when you do what you would do for a healthy person, that unhealthy person, that body is not going to react the same way. Giving food or fluids by tube or IVs often causes more problems than anything positive that happens. So just make sure that folks understand that. And here is the actual post. You see it's just patient information up there at the top. Then section A is either do CPR or do not. Make sure they understand that you're already sick, maybe have osteoporosis if that's the case, but it's not like on television where somebody gives you a few pumps on your chest and you take a deep breath and you come back and everything's Jim dandy. If they are able to bring you back, which is questionable, you will most likely have broken ribs. You will most likely end up in the ICU, possibly on a ventilator hooked up to lots of tubes, and you're going to be hooked up to something when you go there, and you may well die there. If you are sick enough, you may not last long after they're able to bring you back. So would you rather die in the ICU or the hospital, or would you rather have just been left alone the first time you died before they gave you the CPR? And then section B, that's the full treatment, selective treatment, comfort-focused treatment that we talked about a little bit ago. Full treatment is do everything you can to keep me alive, and then you see you can put trial period, so that they know that they'll do it for a week or whatever. And then if it's not working, go ahead and disconnect things. And then selective treatment is like IVs, that sort of thing. Just to kind of see if you get better without a bunch of invasive stuff. And then comfort-focused treatment is just do whatever you can to keep me comfortable, but don't try to do anything really invasive on me, and whatever happens, happens. Section C is the whole feeding tube thing, whether it's NG tube, G tube, J tube, TPN. That's going to be not making anything better. Feeding tubes do not make you better. They just are supposed to be keeping you alive until you recover on your own. Chances are a hospice patient probably won't do a lot of good. So information and signatures. If there's an advance directive, get a copy of that. Write down the date there in the blank where it says date. And then if they have an advance directive but it's not available, go ahead and mark that, and then over on the right hand side make sure you put down who is the agent appointed on that, just so we have that. And then find out, and the social worker will look into this as well, but make sure they understand we would like a copy of that advance directive if they don't have it available during the EOB. And then the signature of physician, nurse practitioner, you probably won't be signing that because you most likely are not one of those things. So just help the patient fill out, or the caregiver, whoever is the signing party, fill out that bottom section. And then the back, make sure you fill out the back. And then your name goes over on preparer name. If you're not the person signing it, if you're not a nurse practitioner, a PA, or a physician, you'd fill your name out there on the right-hand side on the back part. And then if there's an additional contact, another family member that lives outside the house, other than the agent, or even if you just want to put the caregiver on there, go ahead and put that information there on that bottom line. So that's the Pulse. That is the presentation on explanation of benefits. And if you have any questions, you can feel free to give me a call.